previous edema that was in Crohn's disease. We published this paper on retinal cases. I think it will come out in few months. Sorry. And you see that there is a cyst here, and the cyst is visible in autofluorescent image. And I will show you, after treatment, it disappears. But I show you another case, like here, you see in central vein occlusion, there is a cyst here that is quite clear. And why is visible? What increased the fluorescence here? And you can see the cyst.
The light can pass to the cyst more easy than the rest of the retina.
Why?
More
Thinner.
But why is it more transparent?
It's thinner.
The pigment is displaced. So all the macropigment is displayed by cyst, and so you see through. And in fact, if we look at the fluorescein, you see probably better in autofluorescent than not in the early phase of fluorescein. Chronic central serous chororetinopathy. You see an increase of fluorescence here. Until this presentation was done for the first time, this was a real normal sign of central serous, but we couldn't answer. Someone was saying that these are an increase of fluorescence due to the sick RPE cells. The fluid is there for a long time, and the RP cells are not working very nice, and then they accumulate, photopigment. We have an answer right now because we had the spectral domain OCT coupled with an autofluorescent image, and it's easy. And why should increase here? I will show you one image. Sorry about that. I'll try to find we say that remember in juxtafoveal telangiectasia, the macular pigment was not evident. You see, there is no dark spot in the center, and you see that there is an area with an increased autofluorescence that corresponds to this hole, to this cyst in the. And if you look at the fluorescein, you know that juxtafoveal telangiectasia has leakage here, or what we call leakage. And if you go and see the leakage, and you take point by point, the leakage is here, but is not. And this cyst is completely empty. And actually, you see here, this was the increased autofluorescence, and you see that leakage is outside. And it's not. There is no evidence of edema in the neurosensory retina. So we don't know exactly if this is a real leakage or not. And this was just an information. So what is increasing? Why is increasing the fluorescence here? Because there is no photoreceptor. There are no photoreceptor, and so there is no photoreceptor pigment. You see behind. In fact, if you bleach the rest of the photopigment, this part stays stable and this increases. The choroidal hemangioma, you see here, this is a late ICG and autofluorescence. And this is another interesting things. Before photodynamic therapy in chronic central serous, someone suggested to use PDT for decreasing the fluid, and we did once. It's the only one that I did, because after that I never do again. This was the spot that we used. And 1 month later, you see that there is an increase of fluorescence here, here, here. Remember, the spot was there. 9 months later, this increased fluorescence became atrophic. And remember, the spot was exactly there. So it was covering that area that was creating an increase of fluorescence. So in some way it was toxic for the RP cells. And you see the atrophic area there. Light toxicity with the microscope, during the vitrectomy, and that was the image that you can get from a light source during vitrectomy. Siliconoids. It's typical, and these small bubbles, fluorescent bubbles, sometimes are confusing because it can be concentrated in one point or diffuse in all the retina, and sometimes it's not clear exactly what type of disease it is. Choroidal rupture, red-free, infrared, color picture. But look at the autofluorescence. And actually you know exactly also where the blood is located. This is a typical of the optic pit. This exam in Santiago, when 2 years ago I went for a meeting, and we just had the first HRA2, and we played with that, and I saw this patient, and look at the autofluorescent image. You see these little dots are typical of the optic pit. And after that I start to see all the patients with optic pit, and this was another one. It's clear, you see. This is a spectral domain OCT that you can actually see. This patient has 0.8 visual acuity, 24. It's quite impressive to see this type of detachment. You see there is still some connection in neurosensory retina. And, but this is clear, but sometimes it's not so clear. But having these white dots in in the autofluorescent image suggests us to look for an optic peak that after 2 hours we were able to get here, but was not so easy just looking at the fundus and the color picture. So when you see with white dots with an elevated narrow sensory retina, think always to an optic peak. This is a sad story of a patient that has retinoblastoma in one eye, the left eye. Then after 25 years, she had a glioma, was treated for glioma, she had neurosurgery. She did very well, but she underwent to a chemotherapy. After the third cycle, one morning, wake up and was completely blind. And the image 2 months later, and you see such things here that you see clearly in autofluorescence. You see? Now, what is that? One of the possibility, I don't think it's correct, but the drug that she used was fluorescent at the same wavelength. But more than that, I think that this is a whole blood. We saw that the whole blood fluoresces. And you see that there is completely no feeling of this vessel. So it means that the vessel have blood completely stopped. And that probably can give this increased autofluorescence. As a matter of fact, 1 year later, this autofluorescence disappeared. So, until now we spoke about the 488 nanometer autofluorescence. But we have also, and so 488 and nanometer for excitation and barrier 500 nanometers. But we have also the near infrared autofluorescence. And the image that you get is like that. You see, it's a different issue. Here you don't have a decreased autofluorescence, but you have an increased autofluorescence in the same patient. And why you have an increased autofluorescence is not the same patient. But you have an increased autofluorescence, usually in a normal subject, because of the fact that what you look at is the fluorescence that is emitted by melanin. So you know that from an anatomical point of view, the RPE cells in the center of the macula are higher and richer of melanin. So this is why you have an increased autofluorescence in the near infrared, but decrease in the other area. And we'll show you some example of the near infrared autofluorescence. You see that the 480 and the near infrared, you see vessel here, for sure it's an atrophic area. And you see some area where we have an increased autofluorescence that correspond to decreased autofluorescence in autofluorescent image. Central serous chororetinopathy. You see here some dots that you see also in some way in autofluorescence. Remember, for example, that ICG is important in central serous chororetinopathy because it show more leakage area, you see, than not in fluorescence. And usually in a chronic CSR, you have a vein, choroidal vein, and that you cannot see in fluorescein. You see here an increased fluorescence that corresponds to this pigment, or in an EVUS, where you see the near-infrared clearly, very well visible, and as we saw before, nothing visible in autofluorescence. 488, the blue autofluorescence. So in conclusion, autofluorescence, it's a non-invasive tool. I think it's very useful for differential diagnosis, as it's not an invasive test, so you can do without doing any injection. And right now it's also used for pathophysiology of many disease. For example, there is a study by Frank Holz and all the group of German people that create a net for studying the autofluorescence in age-related macular degeneration, where they differentiate the atrophic, geographic atrophy in different type, as we did for drusen, and they can predict which one will grow faster but not the other. A particular pattern that can predict the evolution of the geographic atrophy. If you have any question, I will be more than happy to answer. If you want to have some other information regarding some other possibility, like using infrared or using ICG fluorescing, I'm here. I have all the presentation, so it's up to you.
A question. In diabetic,
Yes.
you have something really
Useful and
useful?
well, autofluorescence is useful just for in diabetic patient for detecting the presence or absence of macular edema without doing any injection, but it doesn't give any information about the disease. Also, because if you think diabetic retinopathy, it's in some way acting on retinal vessel and not the RP. So RPs could be absolutely normal in both subjects. But you have some fluid, some blood that can mask the fluorescence, and you have an indirect way of seeing the macular edema just because the pigment is displaced in both subjects. If the macular edema.
And which one do you think is the most useful for autofluorescence?
Which one of the
Yes, the most common
disease?
disease that.
I think when you do any angiography, it's important to do before an injection an autofluorescent image, always. And actually, it's
to understand.
yes, and in some way, it's the way when we choose at the beginning to do an infrared, and for infrared it's exactly the same. It gives other information. So infrared, autofluorescent, every time we start to think, and we actually, in some way, we have in a different. Yes. In different images, we have the information that we get all together in a color image. And so one of the questions that always people ask me, but with this instrument you have the possibility to do a color picture. But my answer is, who cares about color picture? I want to know, I know that infrared is giving me the information of the RPE and beneath. Blue light is giving me the information of inner limiting membrane. Autofluorescence gives me information about RP cells. And I just want to show you some example, quite interesting, in looking at color and what we think about looking just at color and what actually is the reality. This is the case, my case of last 2 months, because I think it's, I learned from this case so many things that you cannot imagine. Okay, this was a patient, a young lady, but myopic eyes, with a CND here, and probably you agree, some atrophic changes here. This patient wanted to have 1 month before, 1 month and a half before this image, Avastin for directly for this CND instead of PDT, because the other eye 5 years before had some not good results. So she refused PDT and she wanted immediately Avastin. And she did very well. She moved from 0.1 to 0.8 in less than 1 month. So it was particularly good for her. However, in February, we treated December 27. February 13, she came for, complaining for some scotomatous area in the upper area. Now, I will show you the fluorescent before and the autofluorescent before. And as you know, atrophic changes of the RP are visible in autofluorescent here and here, okay? But I will show you also the ICG that I'm used to take for myopic eyes. You know that there are people that say the ICG is not important in myopic eyes. And I will try to convince you that it's crucial to have an ICG. And I'm used to take the early ICG, but in myopic eyes it's good to take the late ICG. And this is the late ICG. And it shows that you have some suffering choriocapillaries. Now, we look when she came back complaining for some scotoma. The lesion, you see, it's fantastic, completely closed. No edema in the central area. But you see some changes, some atrophy here that correspond exactly to the, sick choriocapillary that we saw before any injection. And 1 week later, that was the situation, still increasing. And you see there is increased autofluorescent area here that probably predict an increase of atrophy also there. Now I will show you something that to me was incredible. Cutting exactly here with the OCT, we have such an image. And this instrument is very good because you actually take an image, you take as a reference, and after 1 second, after 10 years, you can actually ask to the machine to get exactly at that point. So it's overlapping perfectly because it's as a particular technique that it's taking exactly the same point. It's a perfect tracking. Now, look you know, for sure there is atrophy, but in fact, what we expect is decrease in tissue here, but in fact there is an increase of tissue or a changing the tissue. And 1 week later, that disappeared. And you remember that we saw some increasing autofluorescence, and you see that increasing here, that was not